allows communities to build programs and services based on their unique needs and responsive to service gaps that exist. What I'd like to do, Mr. Chair, I generally like to complete my presentations, but I do have Carol Hopkins from the Thunderbird Foundation, who is an expert in the field and somebody that we rely on in First Nations across the country, and I'd like to afford her a few minutes of my time to provide some remarks as well. Thank you.
In 2 minutes.
Thank you so much, Chief.
Welcome.
Good morning. My apologies for being late this morning. I'm Carol Hopkins, Executive Director of the Thunderbird Partnership Foundation. Our mandate is actually to implement the Mental Wellness Continuum Framework and the Honoring Our Strengths Renewal Framework. And our focus is in mental wellness, meaning addictions and mental health. I want to also begin acknowledging the invitation and say thank you for that, for sharing the time with the Assembly of First Nations, and wanting to recognize the Algonquin people whose land we are meeting on today. I'd like to start off by taking us back to 2004, when the third report from the Auditor General criticized First Nations and Inuit Health of Health Canada for the third time for not doing enough to mitigate the issues related to prescription drug abuse in First Nations and Inuit communities. Then First Nations Inuit Health established a drug utilization prevention and promotion working group, and that working group had a mandate to do three things. One was to make data more available from the non-insured health benefits. Second was to provide engage First Nations communities in developing and implementing a community-driven response to prescription drug abuse. And the third one was to work with prescribers to address practices and situations with overprescribing. So that was in 2004. We're 12 years later, and one of those issues is still outstanding, and that is the pilot and proposal-driven nature of funding to First Nations communities to address prescription drug use issues. That's the most critical issue when we talk about the opiate crisis amongst First Nations people, is that it's annual funding based on proposals, and that those proposals are not always fulfilled, and it's year-to-year funding, somehow expecting that within a year we're going to be able to take care of the opiate crisis that exists in First Nations communities. So addressing the opiate crisis has been a challenge then, most significantly because of the inconsistent support to community-governed and culturally based treatment. One community-based opioid study misuse report reported that among adults ages 20 to 30 years old, 26% of the community was engaged in a buprenorphine naloxone program. Now, that's 28%. 28% of the community is double the rate of diabetes in that same community. So we have dedicated funding, thankfully, to address the issues related to diabetes in our communities, but we don't have the same type of resources when it comes to dealing with opiate crisis. The Drug Utilization Prevention Promotion Program was successful in demonstrating piloting a number of community-based programs. We also have a Lakehead study that demonstrated the success of community-governed programs to address opiate addictions. We have other programs in Northern Ontario that you'll hear more about, who also demonstrate the importance and significance of their success, unfounded in urban environments and other communities, simply because of the team-based, community-driven, culturally based programs that are offered, and yet they do not have annualized committed core funding within their health envelopes.
Ms. Hopkins, I have